Welcome to the deep dive. Today we're really getting into something quite fascinating and honestly a bit complex about how our bodies work and, well, how they can sometimes go wrong. We're talking about portal hypertension.
That's right. And we've got some excellent material to guide us. Specifically, the chapters covering this in Rutherford's Vascular Surgery and Endovascular Therapy, the 10th edition. It's pretty comprehensive stuff.
Definitely. So our mission here for you listening is to really unpack portal hypertension.
Yeah.
We want to get into the nitty-gritty of why it happens and look at the really quite amazing range of ways doctors try to manage it.
Exactly. We'll focus on the underlying causes, the mechanisms, and the solutions, but, try to keep it understandable without drowning you in medical jargon.
Yeah, think of it maybe like a river system inside you, usually flowing nice and calm. But then imagine blockages pop up, the water backs up, has to find new routes, often not very good ones.
That's a great way to picture it, actually.
And the effects of that backup, that pressure increase, can be surprisingly widespread throughout the body. It's quite something. Okay, so let's dive in. What exactly is portal hypertension?
Okay, so at its core, portal hypertension is just abnormally high blood pressure, but specifically in the portal venous system. Now, this system, it's like a dedicated highway carrying blood from your gut, your stomach, intestines, spleen, pancreas, straight to the liver.
For processing all that stuff we digest, right?
Precisely. Normally, the pressure in this portal highway is pretty low, maybe 5 to 10 millimeters of mercury. We start talking about clinically significant portal hypertension when that pressure gets more than 10 mmHg higher than the pressure in your regular systemic veins.
Okay, so higher pressure. But what causes it? What makes that pressure actually, spike? Is it like a traffic jam?
That's a good analogy. And a bit of basic physics actually helps explain it. You might remember Ohm's law from school. Pressure equals flow times resistance, P equals Q times R. Yeah. Well, in portal hypertension, that increased pressure, the P, it can happen because there's either more blood flow, the Q, trying to get
Well,
through.
something's blocking the way, increasing the resistance, the R.
Exactly. Or, quite often, it's actually a combination of both increased flow and increased resistance working together.
Okay, so increased resistance seems key. Where does that resistance usually build up?
Yeah, resistance is a major player. It can happen inside the liver itself. We call that intrahepatic resistance. Think scarring or inflammation within the liver tissue.
Mhm.
But resistance can also increase in those detour vessels, the collaterals that form when blood tries to get around the liver blockage. That's portocollateral resistance. Compared to a healthy liver where blood flows easily, these factors really ramp up the pressure.
Got it. So definition down. Now let's really dig into the why. What kinds of things actually cause these blockages or resistance changes? You mentioned different locations.
Right. We can classify the causes based on where the problem is relative to the liver. Is it before the liver, like outside it? That's extrahepatic. Is it within the liver tissue itself? That's intrahepatic. Or is it after the blood has passed through the liver? That's posthepatic.
Okay.
And we can even get a bit more specific looking at where the blockage is relative to the liver's tiny filtering units, the sinusoids. So presenoidal is before them, sinusoidal is right at their level, and postsinusoidal is just after them.
All right, let's start before the liver then. Extrahepatic presenoidal. What's the big one there?
By far the most common cause in that category is portal vein thrombosis, or PVT. Basically, a blood clot forms in the main portal vein, the highway entrance to the liver.
Okay, a clot. Why would that happen? Is it different in kids versus adults?
It often is, yeah. In children, PVT can sometimes be triggered by infections, maybe from appendicitis or an infection around the belly button shortly after birth called onphalitis.
And in adults? What leads to PVT?
In adults, it's often more complicated. It could be underlying conditions that make the blood clot more easily hypercoagulable states, we call them, or inflammation, maybe complications from surgery or other medical procedures, sometimes even cancer.
Interesting.
And perhaps surprisingly, cirrhosis itself, which we think of as an intrahepatic problem, is actually a very common reason for adults to develop PVT. The chances of an adult with one of these conditions getting PVT can range pretty widely, maybe from less than 1% up to over 20%.
Wow, quite a range. Okay, so that's clots before the liver. What about blockages inside the liver, but still before those tiny sinusoids?
Yeah.
Intrahepatic presenoidal.
Exactly. Here, the issue is usually fibrosis scar tissue building up, which squeezes the small portal vein branches within the liver. Lots of things can cause this.
Like what?
Well, general liver scarring, obviously, but also conditions like sarcoidosis, where you get these clumps of inflammatory cells, chronic exposure to things like arsenic, Wilson disease, that's a genetic thing where copper builds up. Something called hepatoportal sclerosis, primary biliary cirrhosis, and even certain blood disorders, myeloproliferative disorders, where abnormal cells can kind of clog up those portal areas.
And you mentioned one other big one globally.
Yes, schistosomiasis. It's a parasitic infection, and believe it or not, it's the leading cause of portal hypertension worldwide.
Really? How does a parasite cause this?
The parasite's eggs get stuck in the walls of the small chordal veins inside the liver. This triggers inflammation and scarring, fibrosis, which narrows those vessels and increases resistance. It's a huge public health issue in many parts of the world.
Incredible. Okay, so those are the pre-sinusoidal causes. What about blockages right at the level of the sinusoids or just after them but still within the liver? Intrahepatic, sinusoidal, and postsinusoidal.
Right. So sinusoidal hypertension often comes from direct damage to the main liver cells within those sinusoids. Think alcoholic hepatitis, viral hepatitis, maybe toxins.
Okay.
Post-sinusoidal obstruction, happening just after the sinusoids but before the main hepatic veins leave the liver, is often linked to things that affect blood outflow from the sinusoids. Again, long-term alcohol damage is a big one, but also severe scarring after major liver injury or hemochromatosis where iron builds up.
And cirrhosis keeps popping up. It seems like a major factor across different categories.
Absolutely. In the Western world, cirrhosis, regardless of what initially caused it, is hands down the most common trigger for portal hypertension. The liver gets scarred, forms nodules, and these physical changes definitely obstruct blood flow.
Just physically blocking the paths?
Well, yes, but it's actually a bit more dynamic than that. Cirrhosis also messes with blood flow patterns within the liver. You get these abnormal connections forming between arteries and veins, shunts, and lots of new, inefficient collateral vessels.
So blood takes detours even inside the liver.
Exactly. And maybe about a third of the blood ends up bypassing the functional liver cells altogether. This shunting actually increases the heart's output and lowers resistance in the rest of the body's circulation, which perhaps counterintuitively drives up pressure in the liver veins and the portal vein.
That's complex.
It is. And of course, because so much blood is bypassing the working parts, liver function itself often gets worse.
Makes sense. Okay, covered before, during, and just after the sinusoids within the liver. What about blockages after the blood leaves the liver? Extrahepatic, postsinusoidal.
Now we're talking about problems mainly in the hepatic veins, the big veins draining the liver, or even problems with the heart causing blood to back up. Clots can form in the hepatic veins, sometimes triggered by cancer, trauma, pregnancy, even birth control pills.
And isn't there a syndrome associated with that?
Yes, Budd-Chiari syndrome. That's characterized by hepatic vein obstruction, and it's often linked to underlying blood clotting disorders or myeloproliferative diseases.
Got it. And one last category mentioned was arteriovenous fistulae. How do they fit in?
Right, AV fistulae. These are abnormal direct connections between an artery and a vein. If you get one of these involving the portal circulation, say between the hepatic artery and the portal vein, or maybe in the spleen.
You get a sudden surge of high-pressure arterial blood into the low-pressure portal system.
Exactly. It's like opening a fire hose into that calm river. This massive increase in flow jacks up the portal pressure. And if there's also underlying fibrosis developing, it gets even worse. These can sometimes happen after medical procedures involving liver puncture or from trauma, or related to splenic artery aneurysms or conditions like sarcoidosis or Gaucher disease affecting the spleen.
Wow. Okay, that is a really diverse set of causes,
Yeah.
all leading to this pressure problem in the portal system. So if this is happening, what might a doctor actually see or find when examining someone? What are the clinical signs?
Well, during a physical exam, several things can point towards underlying liver disease and potentially portal hypertension. You might see ascites, that's fluid building up in the belly, making it look swollen.
Like the river overflowing.
Precisely. You might see spider angiomas, these tiny, red, spider-like blood vessels on the skin, usually on the chest or face. Redness of the palms, called palmar erythema. In men, sometimes enlargement of breast tissue, gynecomastia.
What about those veins on the stomach?
Yes, caput medusa. Those are enlarged, visible veins spreading out from the belly button. And you might also notice signs of muscle wasting, particularly in the temples or shoulders.
And beyond just looking at the patient.
Other signs can include things like encephalopathy, which affects brain function, maybe confusion or personality changes, asterixis, which is a sort of flapping tremor you see when they hold their hands out, and often just profound fatigue. But, for many people, the very first indication that something is seriously wrong is actually bleeding from varices.
Variceal bleeding, that sounds bad. What exactly are varices and why are they such a dangerous complication?
They are definitely a major concern. Varices are basically veins that have become swollen, enlarged, and weakened because of that high pressure in the portal system. When the pressure gradient, the difference between portal pressure and regular venous pressure, hits about 10 to 12 mmHg, the body desperately tries to find alternative routes for blood to bypass the blocked liver.
The detours we talked about.
Exactly. These detours are called collaterals. They connect the high-pressure portal veins to the lower-pressure systemic veins, the body's main circulation. But these collateral pathways, while offering less resistance than the blocked portal system, still have higher resistance than normal veins, so they don't fully fix the pressure problem, and they tend to get overloaded.
So these new routes aren't perfect. Where do they usually form?
They mainly develop from the widening of tiny connections we all have from embryonic development, little pre-existing links between the portal and systemic systems. Plus, there's also some abnormal new blood vessel formation, neoangiogenesis. These vessels aren't quite normal, they can be fragile. The most common places you see them are where the portal system connects near the esophagus and stomach. The left gastric vein and the short gastric veins often swell up, leading to esophageal varices in the swallowing tube and gastric varices in the stomach itself as they shunt blood away from the portal system.
I remember reading about different classification zones in the esophagus, types in the stomach. Does that matter?
It does, yeah. It helps doctors assess the risk. Esophageal varices are often described in zones going up from the stomach. There's a transitional zone right near the junction with the stomach that seems particularly prone to bleeding. For gastric varices, type I are kind of extensions of esophageal ones, while type 2 are more isolated in the stomach fundus, the upper part. Knowing the type and location helps guide treatment.
And the caput medusae on the abdomen fits in how?
Those are also varices, just in a different location. They represent collateral flow from the portal system, specifically the left portal vein, connecting through veins around the belly button, periumbilical veins, back into the systemic circulation.
So just how common are these esophageal and gastric varices in people with cirrhosis?
They're pretty common. About half of people with cirrhosis might have them when they're first diagnosed. And if you follow people long-term, that number climbs to around 90%.
And the risk of them actually bleeding?
It depends heavily on their size and also how high the pressure is. Small varices, maybe less than 5 millimeters, have roughly a 7% chance of bleeding over 2 years. But large varices, that risk jumps up significantly, maybe around 30% over 2 years. So size is a big predictor.
And if they do bleed?
The consequences can be really severe, unfortunately. Mortality from a first variceal bleed can be as high as 35%, and the risk of rebleeding within a year is substantial, around 60%. Each subsequent bleed also carries a significant risk, maybe 20% mortality.
Why do they rupture? Is there a specific mechanism?
The leading idea is often called the explosion hypothesis. Basically, as the pressure inside the barracks rises, say above 10 mmHg or so relative to the surrounding tissue, the vein wall stretches and thins out like an overinflated balloon. Eventually, the tension in that thin wall becomes too much for its strength, and it ruptures. It relates to a physics principle, the law of Laplace, about wall tension in cylinders. We also know there's a critical pressure level we measure, the hepatic venous pressure gradient, or HVPG. If that gradient is above 12 mmHg in someone with varices, their rate of bleeding is much higher.
So keeping that pressure below 12 is a key goal.
Exactly. A lot of our treatments, both for preventing a first bleed and preventing rebleeding, are aimed at reducing that portal pressure, specifically getting that HVPG below the 12 mmHg threshold.
Okay, variceal bleeding is clearly a huge issue. What about the other complications? We mentioned ascites, the fluid buildup.
Yes, ascites is another major one. It happens in up to 80% of people with significant portal hypertension. That high pressure in the portal veins basically forces fluid out of the blood vessels into the abdominal cavity. Think Starling forces, if you remember those.
Pushing fluid out.
Right. And it's often made worse because people with advanced liver disease often have low levels of albumin, a protein in the blood that normally helps keep fluid inside the vessels. So you have increased pressure pushing fluid out and decreased protein pulling it in. Plus, the lymphatic system, which usually drains excess fluid, just gets overwhelmed.
The river overflows its banks, and the drainage system is clogged.
A perfect analogy.
And ascites isn't just uncomfortable, right? It can lead to other problems.
That's correct. A big risk is spontaneous bacterial peritonitis, or SBP. That's an infection of the acidic fluid itself. Historically, it was mostly gut bacteria, but we see other types now too. It's serious. About 30% of patients with ascites end up hospitalized for SBP, and it definitely increases mortality in people with cirrhosis.
Okay. And then encephalopathy, the brain effects. How does portal hypertension cause that?
Hepatic encephalopathy is basically brain dysfunction caused by liver failure. When the liver isn't working well, and especially when blood is shunted around the liver because of portal hypertension, substances that the liver normally clears out ammonia is the classic example buildup in the bloodstream.
And these toxins reach the brain.
Exactly. They cross into the brain and mess with the function of certain brain cells, particularly astrocytes. This can lead to problems with energy metabolism, brain swelling, and a whole spectrum of neurological symptoms.
From subtle to severe.
Right. It can range from just mild confusion, maybe changes in sleep patterns, personality shifts, all the way to deep coma and potentially death if the swelling is severe. We use grading systems like the West Haven criteria to classify how bad it is. It affects maybe 30–40% of people with decompensated liver failure, and it's a bad sign. But importantly, it's often reversible if you catch and treat the underlying trigger early. And
Epidural syndrome, HRS kidney failure on top of liver failure.
Yeah, HRS is a really tough complication. It's basically worsening kidney function that develops specifically in the setting of advanced cirrhosis and ascites after you've ruled out other causes of kidney injury. People develop low urine output, low sodium in the blood. It can happen rapidly over just a couple of weeks or more slowly. The rapid kind has a very poor prognosis.
Grim. And lastly, hepatopulmonary and portopulmonary syndromes. Lungs involved now.
Yes, these link portal hypertension to lung problems. Hepatopulmonary syndrome involves abnormal widening of blood vessels in the lungs, leading to problems with oxygenation. You might see shortness of breath, maybe finger clubbing. Portopulmonary syndrome is actual high blood pressure in the lung arteries associated with portal hypertension. In both cases, though, it's usually the underlying liver failure that dictates the outcome, more so than the lung issue itself.
So this cascade of potential problems is really striking. How do doctors actually pin down the diagnosis of portal hypertension and figure out the cause? What tests are run?
It's usually a combination of things. History and physical exam give clues, but then we rely on lab tests, endoscopy, imaging, and sometimes a liver biopsy. The initial blood work is usually pretty broad, checking blood counts, clotting factors, liver enzymes, kidney function, electrolytes, blood gases, maybe lactate.
What about ammonia levels? You mentioned that with encephalopathy.
We often check ammonia, but interestingly, the level doesn't always correlate perfectly with how severe the neurological symptoms are. It's just one piece of the puzzle. Overall, the labs help determine if the liver problem is acute or chronic and how severe it is.
And then tests for specific causes.
Right. Depending on the situation, we'd test for viral hepatitis, maybe HIV, look for markers of autoimmune conditions, check copper levels for Wilson disease, iron for hemochromatosis, things like that. Oh, and an interesting point, men with cirrhosis often have low testosterone levels, which seems linked to worse outcomes.
Okay, and endoscopy, looking inside with a camera, you said that's crucial.
Absolutely essential. Upper GI endoscopy lets us directly visualize the esophagus and stomach to see if varices are present, how big they are, and if they look like they're at high risk of bleeding. Everyone suspected of having portal hypertension should probably have one.
Even if they haven't bled?
Yes. And if someone has bled, they'll need repeat endoscopies, maybe every few months initially, to monitor things and sometimes repeat treatments like banding. Endoscopy can also spot other issues like canstropathy, ulcers, or tears.
What about a liver biopsy? Is that standard?
Not always needed just to diagnose portal hypertension if the picture is clear, but it's often very helpful to determine the underlying cause of the liver disease and assess the degree of damage or scarring, the fibrosis.
What can you see on a biopsy?
You can see the characteristic features of cirrhosis, the nodules, the scarring, but you can also see specific clues. Certain inflammatory cells in hepatitis B, fatty changes in Mallory-Dank bodies and alcoholic liver disease, the pipestem fibrosis, and maybe even parasite eggs and schistosomiasis, it really helps nail down the why.
And imaging. How do you look at the blood vessels themselves?
Duplex ultrasound is a really good first step. It's non-invasive, uses sound waves, and can show if the portal vein is open, if there's a clot, and which way the blood is flowing. It's vital for planning interventions like TIPS or surgery and for follow-up afterwards.
What about CT scans?
CT angiography, or CTA, gives very detailed pictures of the blood vessels using contrast dye. It's great for looking at the portal vein, checking for clots, and also assessing the liver itself for nodules or tumors, assuming the patient's kidney function is okay to handle the dye.
And then there's percutaneous angiography. Is Sounds more invasive.
It is. Transhepatic portal venography involves putting a needle directly through the skin into the liver to access the portal vein. You can then inject dye to get a detailed map of the portal system and directly measure pressures, like the hepatic wedge pressure.
When would you do that?
It's not routine, but it can be really important before complex surgical shunts to understand the exact anatomy. It can also show the extent of cirrhosis, collateral vessels, and sometimes even reverse flow in the portal vein in really advanced cases.
Okay, so a whole battery of tests to get the full picture. Once you have the diagnosis, let's talk treatment. What are the non-surgical approaches?
Right. The main goals here are to prevent or manage those major complications we discussed: variceal bleeding, ascites, and encephalopathy.
Let's start with variceal bleeding again. How do you try to prevent a first bleed? Primary prophylaxis.
Two main strategies here: medications, specifically non-selective beta blockers, and endoscopic treatments.
Beta blockers, like for high blood pressure.
Similar, yes. Drugs like propranolol or carvedilol reduce cardiac output and cause some constriction of blood vessels in the gut, which together lower the pressure in the portal system. They're recommended for anyone with medium or large varices, and sometimes for small ones if they look high risk. Carvedilol might have some extra benefit.
And the endoscopic options.
The main one is endoscopic variceal band ligation, or EVBL. Using the endoscope, little rubber bands are placed around the base of the esophageal varices. This cuts off blood flow, they shrivel up and fall off. It's very effective for medium to large varices.
What about injecting them? Sclerotherapy.
Sclerotherapy, injecting a scarring agent, is another option. It's perhaps used more often now for gastric varices, where banding can be tricky. For esophageal varices, banding is generally preferred for prophylaxis. There are some risks with sclerotherapy, like potential embolization of the agent, but it can be effective.
Okay, that's prevention. What if someone is actively bleeding right now? Acute variceal hemorrhage.
That's a true emergency. First, stabilize the patient. Manage blood loss cautiously. Then medications are key. Vasoactive drugs like terlipressin or somatostatin and its analog octreotide are given intravenously.
How do they work?
They constrict blood vessels in the splanchnic circulation of the gut, which reduces blood flow into the portal system and lowers the pressure, helping to stop the bleeding. They've been shown to improve control of bleeding and even survival.
And then endoscopy again.
Yes. Urgent endoscopy is crucial. Usually, band ligation, EVBL, is the first-line endoscopic treatment for bleeding esophageal varices. Sclerotherapy can also be used, sometimes in combination or if banding fails. For bleeding gastric varices, injecting a tissue adhesive like cyanoacrylate glue is often very effective.
What if those don't work?
If medications and initial endoscopy fail, you might need temporary measures like balloon tamponade, inserting a special tube with balloons to physically press on the bleeding varices. But that's really a bridge to something more definitive because of potential complications.
Like what?
Procedures like TIPS, that transjugular intrahepatic portosystemic shunt we mentioned, or sometimes more specialized embolization techniques done via catheters, like BRTO or BETO, especially for gastric varices fed by specific collateral veins.
Tell us more about TIPS. It seems really important.
It is. TIP-PS creates a low-resistance channel, a shunt, directly between a branch of the portal vein and a hepatic vein, right through the liver tissue. It's done via catheters inserted through the jugular vein in the neck, guided by imaging. A stent graft is placed to keep the channel open.
And the goal?
The goal is to dramatically lower the portal pressure, usually aiming for that gradient, HVPG, to be below 12 mmHg. It's highly effective, technically successful in about 97% of cases, and great for controlling refractory variceal bleeding and also difficult to manage ascites. There's evidence that doing TIP-PS early in high-risk bleeding patients improves outcomes.
Okay. And after a bleed has been stopped, what about preventing another one? Secondary prophylaxis.
Absolutely critical. The risk of rebleeding is very high, maybe 80% within a year without prophylaxis. The mainstays here are combination therapy, non-selective beta blockers, plus serial endoscopic band ligation. That combination significantly reduces rebleeding risk, maybe down below 50%.
What about TIP-PS for secondary prophylaxis?
TIP-PS is also very effective at preventing rebleeding, perhaps even more so than endoscopic therapy plus beta blockers. However, it does carry a higher risk of causing or worsening hepatic encephalopathy because more blood bypasses the liver's filtering function, so it's a trade-off to consider.
Makes sense. Okay, shifting gears to ascites. How is that managed non-surgically?
First line is usually diuretics. Spironolactone is often the starting point, and furosemide is frequently added. They help the kidneys excrete more salt and water, reducing the fluid buildup. We adjust the doses based on response and monitor electrolytes carefully.
What if diuretics aren't enough or cause problems?
Then the options are large volume paracentesis, physically draining the fluid from the abdomen with a needle, often repeatedly or considering tips, which can also be very effective for refractory ascites by lowering the portal pressure.
And for encephalopathy, what's the non-surgical approach?
First, identify and correct any precipitating factors like infection, dehydration, electrolyte problems, constipation, or recent GI bleeding. Then, the main goal is to reduce the amount of ammonia being produced in and absorbed from the gut.
How do you do that?
Lactulose is the workhorse medication. It's a non-absorbable sugar that makes the gut environment less friendly for ammonia-producing bacteria and also acts as a laxative to help clear ammonia out. Another option is certain antibiotics, like rifaximin, which can reduce the gut bacteria that produce ammonia. Neomycin used to be used, but less so now due to potential kidney and hearing toxicity with long-term use.
Okay. And one last non-surgical bit. Hepatic and portal vein recanalization, reopening blocked veins.
Right. If the portal hypertension is caused or complicated by a clot in the hepatic veins, Budd-Chiari, or the portal vein itself, sometimes we can use endovascular techniques, catheters, balloons, stents to reopen that blocked vein.
What's the benefit?
For Budd-Chiari, successful recanalization of the hepatic veins can dramatically improve symptoms and might be as effective as TIPS, but with potentially fewer complications like encephalopathy. For portal vein thrombosis, reopening the vein, often combined with TIPS, can improve liver function, reduce complications, and sometimes make a patient a better candidate for a liver transplant if needed.
That's a pretty impressive arsenal of non-surgical tools. What about actual surgery? When does that come into play?
Surgical portosystemic shunts creating a direct surgical connection between the portal system and the systemic circulation were developed quite early on. They are very effective at preventing recurrent variceal bleeding.
But you mentioned they aren't usually done preventively?
Correct. Prophylactic shunting, before any bleeding has occurred, didn't show a survival benefit over medical therapy and led to more encephalopathy, so that's generally not recommended. Even for secondary prophylaxis, while shunts reduce rebleeding more than endoscopic therapy, a clear long-term survival advantage hasn't always been shown, and encephalopathy remains a concern. Emergency shunting for active bleeding is also rarely done now because non-surgical options are usually effective, and surgery in that setting carries high mortality.
So when are surgical shunts used today?
They still have a role, particularly in certain situations, maybe if TIPSIS isn't feasible or has failed, or in patients with good liver function but recurrent bleeding despite other therapies. The choice of shunt type matters too.
What are the main types again?
Broadly, non-selective versus selective. Non-selective shunts, like a portocaval, portal vein to vena cava, or mesenteric, mesenteric vein to vena cava, often with a graft, divert essentially all portal blood away from the liver.
And selective.
The main selective shunt is the distal splenorenal shunt, or Warren shunt. The idea here is to disconnect the veins draining the spleen from the portal system and connect the splenic vein to the left kidney vein. This selectively decompresses the esophageal and gastric varices while, ideally, preserving blood flow to the liver through the portal vein.
Does that reduce the encephalopathy risk?
That was the hope, and studies generally show lower rates of encephalopathy with selective shunts compared to non-selective ones. Whether there's a significant difference in long-term survival is less clear, and selective shunts are technically more complex.
How do surgical shunts compare to TIPIs overall?
It's complex. Some studies comparing, say, TIPS versus a distal splenorenal shunt find similar rates of rebleeding and survival, but TIPS often requires more re-interventions for shunt dysfunction, stenosis, or clotting. Surgical shunts tend to have better long-term patency, but are obviously a bigger upfront operation. In very complex cases, some data suggests surgery might offer better long-term shunt failure-free survival. The choice really depends on local expertise, patient factors, and the specific clinical scenario.
So surgery still has its place, but it's more selective now.
Exactly. Operative shunting remains a valuable tool in the armamentarium for managing complicated portal hypertension and bleeding varices, particularly for long-term control in appropriate patients.
And the final piece of the puzzle, liver transplantation.
Right. Liver transplantation is the definitive treatment for end-stage liver disease. It's not usually performed just for portal hypertension or varices if liver function is otherwise okay, but often severe portal hypertension complications are happening because the liver is failing.
So it's the endpoint for many with severe cirrhosis.
Yes. And interestingly, there's some suggestion that patients who have had a surgical shunt prior to transplant might actually do better post-transplant than those managed solely with endoscopic therapies, though that's debated. And occasionally, a successful shunt might stabilize someone with relatively preserved liver function enough that they don't need a transplant, or at least not immediately.
It really drives home how tailored the approach needs to be. That treatment algorithm you mentioned from Rutherford's, does it summarize this nicely?
It does provide a good framework. For an acute bleed, it emphasizes immediate vasoactive drugs, prompt endoscopy with banding or sclerotherapy. If that fails, options like TIPS, possibly BRTO for gastric varices, or even a selective shunt are considered, with balloon tamponade as a temporary bridge if needed.
And for patients who haven't bled yet?
For those with known portal hypertension and varices, it generally starts with non-selective beta blockers, regular endoscopic surveillance, and considering EVBL based on varic size and risk features. If gastric varices are a persistent issue and TIPS isn't ideal, BRTO might be an option. It highlights that stepwise escalating approach.
So wrapping this up, portal hypertension is clearly this incredibly complex condition. It all stems from that increased resistance or flow in the portal system, right?
Fundamentally, yes. And understanding the different causes based on where the problem lies before, within, or after the liver, and then seeing that cascade of potential complications, the varial bleeding, the ascites, the encephalopathy,
Yeah.
it really underscores how vital the liver is and how problems there ripple outwards.
And the progress in managing it is pretty remarkable. From medications and advanced endoscopic techniques to TIPS and selective surgery.
Absolutely. The evolution of treatments, especially the less invasive endovascular options like TIPS and BRTO, alongside improvements in medical management, has really changed the landscape over the last few decades.
It makes you wonder, looking forward, given this intricate link between the liver and the circulation, what might future therapies look like? Could we intervene even earlier?
That's the exciting frontier, isn't it? Thinking about targeting the very initial steps. What if we could develop therapies aimed directly at those hepatic stellate cells that drive fibrosis? Or find better ways to counteract the splanchnic vasodilation, that widening of blood vessels in the gut that increases chordal inflow? Could we offer a truly preventative approach, stopping the cascade before it really gets going?
Intervening at the molecular level almost.
Potentially. The field is definitely moving towards more targeted, perhaps less invasive strategies. Understanding the fundamental biology continues to open up new possibilities. It's a challenging area, but also one with a lot of ongoing innovation.